Human clinical trials can be divided into different stages called phase 1, phase 2, phase 3, and phase 4.
For the phase 1 trials, they are only recruiting only a few patients between 20 and 80 that is carried out on healthy volunteer or who has disease. Normally, this trial takes several months before move to the next phase. Phase 1 trial is to ascertain safety. At this phase, the dose given is gradually increased from one group to another group until the best dose to be given is found, and approximately only 70% of drug are able to move to the next phase. Phase 1, the drug will pass to the phase 2 trials. These phase trials are often larger than phase 1, which involve about 300 until 500 individuals with disease condition, and it takes several months to 2 years to complete the phase. Conducted in order to know whether the new treatment worked well enough to test in a phase 3 trials, to identify more about the side effects and how to manage them, and lastly, to find out the best dose to be used for the patients. New drug is compared with established standard drug or with placebo. If it is shown the new treatment is good as existing treatment, it will move to the phase trial 3. There are only 33% of drugs move to the third phase.
Phase 3. It is for the comparison of new treatments with the best currently available treatment. It also involves many more patients to show the difference. Phase 3 is the most expensive, time-consuming, and difficult trials to design or run. It also conducted by randomized, which the people taking part is put into treatment. The randomization is done by the computer and certain details are considered like age and gender. The randomization is done to ensure that the last phase in the clinical trial is phase 4. This phase is conducted after the drug has been granted license from DCA. The objective of this phase is to find out about the drug side effects, safety.
Generally, all sulfonylurea drugs can cause hypoglycemia, but each generation have different side effects. For first generation, the common side effects are headache, dizziness, paresthesia, abnormal discomfort, and nausea. Propopamide has longer duration of action that leads to hypoglycemia, while acetazolamide was withdrawn from use and no longer available. It also can cause abnormal liver function. Next, for second generation, common side effects are weight gain, and the rest is same with first generation. Glibenclamide can cause hypoglycemia in 20% to 30% patients. These drugs are 100 times more potent with short half-life. It can be administered in low doses and can be given once daily. It can increase risk of cardiovascular disease and contributes to low risk of hypoglycemia in chronic kidney patients. It must be avoided by a patient with severe renal impairment. Lastly, for third generation, it can cause mild reduction in insulin resistance. It gives low risk of hypoglycemia, which is only in 2% to 4% patients. It is safer for people with advanced kidney disease, and it do not block normal relaxation of blood vessels and do not affect coronary arteries. From this table, drug potency increased across generation. The improvement on drug formulation can be seen as the dose range and dose per day is lower, but the effect still same.